Hello everyone, this is ENT student. The topic is preparation of the patient for surgery. Consent taking. Obtaining patient consent for planned surgery. Currently in the UK, the process of obtaining informed consent for planned surgery is carried out by a member of the surgical team, ideally by the surgeon who will be performing the operation. In taking consent, it is important that full information is provided to patient regarding its indications for proposed treatment, including implications, significance, as well as common risks. Some ENT departments, as in Cambridge University Hospital, have consent forms for specific surgeries such as tonsillectomy, tympanoplasty with detailed surgical risks relevant to specific operations. The process of consent should be seen as stimulus for active discussion with patients about treatment options and decision making following that discussion. ENT UK have proposed 22 patient information leaflets which cover some operations but also conditions. Patients who have consented to surgery are considered to have implied consent to anesthesia. A specific written consent for anesthesia is not required in the UK. However, as anesthesia is associated with its own specific risks that are quite distinct and separate from those associated with the surgery, anesthetists are advised to obtain specific consent for anesthesia. Ideally, each patient should receive a general leaflet about anesthesia in the outpatient clinic. This allows the patient time to consider relevant anesthetic issues. Anesthesia. Discussion between anesthetists and patients should include previous medical, surgical, anesthetic history, including problems such as latex allergy, anaphylaxis, difficulty or failed intubation, pulmonary aspiration, postoperative nausea or vomiting, awareness, succinylcholine apnea, malignant hyperpyrexia, unexpected admission to a high dependency or intensive care unit, likely difficulties in provision of anesthesia for planned surgeries, example, possibility of fiber optic tracheal intubation, tracheostomy under local anesthesia, alternative method of securing the airway. Local anesthesia options, either as an adjunct to analgesic or as an alternative to general anesthesia. General conduct of general anesthesia to include fasting advice, pre-medication, administration of intravenous fluids, blood transfusion, pain relief, control of nausea or vomiting, urinary catheterization, nasogastric tube insertion, placement of arterial and central venous lines. Immediate recovery period and post-operative destination, example, high dependency unit or intensive care unit or ward or daycare discharge. Complications related to anesthesia as dental damage, cardiovascular complications. Patient anxieties in relation to anesthesia predominantly around the issues of death, brain damage, intraoperative awareness, loss of control, memory loss, pain control, nausea or vomiting, and needle insertion. In the UK, the preoperative anesthetic visit often occurs only minutes before planned surgery. Ideally, all patients should be seen in the outpatient anesthetic clinic before surgery. This gives time for proper preoperative assessment, preoperative preparation, discussion of anesthetic options, and this is what UK services should strive for as it allows for better patient satisfaction, same day admissions, therefore better use of resources and a smaller likelihood of short notice cancellation due to poor patient preparation. Patients should have adequate time to consider the indications, implications of any potential operation. The process of informed consent for a surgery is continuous process, and rushing a patient to give consent has ethical as well as medico-legal consequences. The UK General Medical Council Code of Good Medical Practice was updated in 2008 and comprehensively covers consent issues. Ideally, the consent for elective procedures should be taken in well in advance of the proposed surgery, example, at pre-assessment clinic. This gives the patient time to assimilate the information, discuss with family members if they wish, and make appropriate choice. There have been successful cases of litigations when consent has been taken on the day of surgery. There is specific consent form in the UK both for parents consenting for children and for those adults that are unable to consent, in incapacity form. For those adults that lack capacity, the clinician has to record on this form how they have come to conclusion that the patient lacks capacity to make this particular healthcare decision and why the proposed treatment would be in the patient's best interest. Acute pain management. Acute pain management plans are made after discussion with the patient in preoperative period. Modifications to WHO analgesic ladder may be useful when considering prescribing postoperative analgesia for patients. Some patients may already be on analgesics preoperatively. Those patients who are on large doses of opioids preoperatively will require large amounts of analgesia intra and postoperatively to treat pain. Earlier liaison with acute pain should be made for patients in whom acute pain is anticipated to be difficult to manage. Simple analgesics include paracetamol, ibuprofen, or diclofenac. The vast majority of patients undergoing surgery will receive some intravenous opioid intraoperatively. Example: fentanyl, alfentanil, morphine. Some patients may require continuing opioids such as codeine or morphine for period of postoperative. Tramadol is another analgesic that may be considered. Drugs should be given orally as far as possible. If they cannot taken orally, then other routes to be considered include sublingual, parenteral including patient-controlled analgesia, rectal suppository, nasogastric or percutaneous endoscopic gastrostomy, radiologically inserted gastrostomy tube, transdermal patch. It is important to know doses, duration of action, contraindications, side effects of analgesics prescribed. The British National Formulary can be a useful guide if there are no local prescription procedures in the place. The correct dose of analgesic for individual patients should be given at regular intervals to achieve adequate pain relief with minimal side effects, titrated according to pain intensity using regularly measured pain severity scores. It is important to ensure that the patient understands and is involved in their pain management. As part of multilodal analgesic delivery, surgeon can infiltrate wound sites with Kirocaine or levobupivacaine 0.5%, maximum dose 2 mg per kg body weight at end of surgery. Elastomeric pumps that can deliver local anesthetic infusions into wounds are also used particularly in free tissue transfer surgery. By providing a continuous infusion, the pumps have the potential to provide continuous analgesia, eliminating the peaks and troughs in analgesic effect that occur with intermittent local or systemic analgesics. Unlike simple incisional infiltration with local anesthetics, evidence for efficacy of local anesthesia wound catheters is abundant. In a recent systemic review, it was concluded that continuous local anesthetic wound infiltration resulted in consistently reduced requirement for postoperative opioids, a subsequent reduction in postoperative nausea and vomiting, quicker return to normal bodily function and ambulation, and reduced length of hospital stay, especially in cardiothoracic and orthopedic populations. Despite cost of the equipment, reduction in complications may lead to overall cost savings. Local anesthetic infiltration and infusion have recently been incorporated into enhanced recovery programs. Thank you.